Hello, I'm Dr. Mark Melin. I'm a vascular surgeon, and we're going to discuss my personal journey to understanding lymphedema and Phlebolymphedema. An honorarium has been provided by Tactile. I'm a member of the Speakers Bureau for Tactile, and Google Images and Tactile Images have been utilized for this presentation. In medical school, we were all taught the classic Starling principle that Ernst Starling developed in 1896. This microvascular fluid exchange model discusses hydrostatic pressures which push fluid through the artery and the capillaries into the interstitium, where the vast majority is then reabsorbed by the veins. We can see in this image that Dr. Starling demonstrates again that net fluid movement is out of the arteries and subsequently is reabsorbed in the post-capillary venules. As a practicing vascular surgeon, I typically evaluated varicose veins in an isolated fashion, looking at the classic CEAP, standing for Clinical, Etiology, Anatomic, and Pathophysiology clinical classifications. In the clinical classification, Class 1 stands for telangiectasias, Class 2 is the type ordinary varicose veins, Type 3 is the presence of edema, Type 4 is development of hyperpigmentation and skin changes such as eczema. Class 5 is a healed venous ulcer, and Class 6 is the presence of a venous ulcer. In my early practice as a vascular surgeon, I had an underappreciation of the degree of lymphedema impact on the patients that I served, especially with advanced venous disease. And it wasn't typically until patients presented in these very advanced phases of lymphedema that I would begin to recognize the presence of significant interstitial edema and advanced lymphedema stages. As I evaluated more data, I became aware of the importance of recognizing lymphedema in association with venous disease, now known as Phlebolymphedema. Phlebolymphedema begins in the C3 status and has now been definitively demonstrated by near-infrared imaging to exist with lymphatic dysfunction in late stages of C3, C4, C5, and C6. This is representing a new dawn in the era of lymphedema management, and it's important to recognize that lymphedema is closely linked with advanced vascular venous disease. But the average medical student still only receives 30 minutes of education on lymphatics and venous dysfunction. The Glycocalyx is a gel-like impermeable layer that lines all blood vessels down to the 5-micron level. There's approximately 60 to 100,000 miles of arteries, veins, and lymphatics in our body. The importance of the recognition of the Glycocalyx is that it alters the classic Starling understanding and prevents reabsorption of interstitial fluid into the veins. The role of the healthy Glycocalyx is fourfold. It improves endothelial function. As the little hairs of the Glycocalyx move, it results in a shear force that can release nitric oxide. It decreases permeability and therefore does not allow fluid reabsorption into the veins as the classic Starling model described. It is very important in terms of coagulation and inhibits platelet adherence and has an important impact on coagulation regulatory factors. The importance of preventing inflammation by preventing leukocyte adhesion, which subsequently can increase the risk of chronic venous disease. In the revised Starling principle, we note that the Glycocalyx prevents reabsorption of lymphatic fluid into the vein, and now we recognize that 100% of all lymphatic fluid must enter the lymphatics to be returned to the venous system. The clinical implications, as described by Michael and Mortimer and Roxon, describe that all chronic lymphedema indicates an inadequacy of failure of lymphatic drainage. This now has a significant implication for how we treat lymphatic and venous disease, in that we have to treat both the lymphatic as well as the venous disease to achieve maximal patient outcomes. Near-infrared imaging, a science advanced by Dr. Eva Sevic Maraca, has demonstrated that lymphatic dysfunction exists within advanced venous disease. By the introduction of indocyanine green into the subdermal lymphatic collection system, we can note in the initial panel that there is normal function. However, in a patient that has congenital lymphatic disorder, there's significant dermal backflow. When this was performed in patients that had C6 disease with open venous ulcers, it demonstrated significant dermal backflow, and with the use of an advanced pneumatic compression device, there was significant clearing of the subdermal lymphatic collections. This is also noted in the patient that has C4 disease in the lower panels. Phlebolymphedema disease progression is again now recognized both in near-infrared imaging, which we can correlate with clinical and physical findings and have a significant impact on how we now should treat patients with a recognition. This slide demonstrates the progressive spiral of lymphatic dysfunction. With advanced phlebolymphedema, the lymphatic system is overloaded, resulting in compromised immune response. This increases the risk of skin infection and cellulitis. With the development of cellulitis, lymphatic function is further compromised and can be even further damaged. This can result in skin fibrosis and subsequent progressive lymphatic damage, and the vicious cycle continues. The cost of cellulitis and skin infections was recently published in JAMA Dermatology in 2019. This was a retrospective cohort analysis of U.S. national readmission rates and utilized 2014 nationwide readmission database. In this cohort, 9.8% of almost 450,000 cellulitic admissions were associated with non-elective readmissions within 30 days. This resulted in a total cost of more than $500 million for all-cause non-elective readmissions, and the readmissions for skin and subcutaneous infections cost more than $100 million. Obviously, this is a significant economic burden. The economic burden directly related to venous leg ulcers was published by Dr. O'Donnell et al. In Journal of Vascular Surgery in 2014, and this demonstrates in a real contemporary vascular practice a total cost of approximately $10,500 over the course of 120 days of cost. The total cost was threefold higher if the ulcer failed to resolve. Nearly two-thirds of the admissions were for treatment of cellulitis with intravenous antibiotics that were resistant to the typical cares of outpatient treatments. Again, the overall burden from an economic value as well as from a societal value for treatment of venous leg ulcers is significant. Most of this is related to the undiagnosed aspect of the associated phlebolymphedema. Another study that demonstrates the economic burden of cellulitis infections in venous leg ulcers demonstrated healthcare system spending for a single episode of cellulitis, including 4 days of hospitalization, was approximately $16,000. If we evaluate total cost per year for a venous leg ulcer, it's approximately $15,700 and can more than double to $30,000 to $35,000 for those venous leg ulcers that fail to heal. Dr. Wade Farrow, who developed the Farrow Wrap, wrote an excellent study in 2010 regarding the underdiagnosis and undertreatment of phlebolymphedema within the wound clinic environment. He stated that simple compression concentrates proteins, creating a pro-inflammatory environment. The proteins and the pro-inflammatory cytokines can subsequently lead to tissue fibrosis. This can then result in breakdown of skin integrity, resulting in bacteria rapidly propagating into the subdermal protein-rich lymphatic fluid. This subsequently can result again in that cycle of cellulitis, decreased function in the lymphatics, and subsequent progressive fibrosis and damage of the lymphatics. Successful treatment of phlebolymphedema requires appropriate drainage of the protein-rich lymph fluid that is within the subdermal collection. And again, we've demonstrated based on near-fly data and based upon our understanding now of phlebolymphedema that this requires treatment of the lymphatic system and not simply treatment of the venous insufficiency. In the 2015 Journal of American Medical Association Dermatology study that evaluated cancer and non-cancer patient treatments of lymphedema, with utilization of an advanced pneumatic compression device, FlexiTouch had a significant impact on a reduction in rates of cellulitis by almost 80%, a 54% reduction in the rate of inpatient hospitalizations, a 40% reduction in the rate of outpatient hospital visits, and this was summated in an overall reduction of total cost of 37%. A New York study performed in 2015 also demonstrated that utilization of FlexiTouch had a significant reduction of cellulitic episodes and a significant reduction in overall number of venous leg ulcers. In the 2018 Journal of Vascular Surgery study, FlexiTouch was compared to other advanced pneumatic compression devices in the scope of conservative therapy. It's important to note that when we discuss FlexiTouch therapy, it is not a standalone therapy and should be utilized in the setting of cares through a lymphedema clinic with a physical therapist or an occupational therapist. When we compare FlexiTouch with conservative therapy to conservative therapy alone, there is a significant cost reduction of approximately 69% when conservative therapy and simple pneumatic devices are compared to conservative therapy plus FlexiTouch. There is an 85% cost reduction. And when we compare other advanced pneumatic compression devices used in the scope of conservative therapy compared to conservative therapy with FlexiTouch, we see, again, a significant reduction in overall cost of 53%. This slide demonstrates that venous and lymphatic disease is again intimately associated in terms of dysfunction as the venous disease becomes more progressive. Physicians recognize C2 disease as typically type ordinaire varicose veins. In C3, we recognize the onset of edema. In C4, we recognize skin changes and subsequent fibrosis. In C5, we recognize a healed ulceration, and C6 is a current active venous leg ulceration. The importance of recognizing Phlebolymphedema existence within the C3 to C6 patients allows improved patient outcomes when appropriate treatment of lymphedema is performed. In conclusion, venous and lymphatic anatomy and disease states are undertaught as part of the U.S. medical system, each medical student now receiving less than 30 minutes of education in years 1 and 2. The recognition of the Glycocalyx has resulted in a revision of the 1896 Starling principle, and we now understand that 100% of lymphatic interstitial fluid must return through the lymphatic system, and no fluid is returned through the venous circulation. This also implies that all chronic edema is a result of inadequate lymphatic drainage. The development and advancement of near-infrared imaging has helped us to understand and correlate chronic lymphatic dysfunction with advanced venous disease. Lymphatic dysfunction and Phlebolymphedema are associated with an increased risk of cellulitis, chronic inflammation, and progressive lymphatic damage, and we know this to be a vicious circle that until we treat the underlying lymphatic dysfunction is difficult to arrest. Venous leg ulcers and cellulitis are associated with an increased rate of hospitalization, outpatient care, and medical resource utilization. FlexiTouch Plus, when used as part of dual therapy through a certified lymphedema clinic that utilizes manual lymphatic drainage and complete decongestive therapy, has been now clinically proven in multiple studies to be economically advantageous by decreasing cellulitis, hospitalizations, and outpatient visits. Thank you.